You see the now ostium of the left circumflex.
It's fine.
Do you want to re-enter into the sac with the balloon, small, low pressure, keep it 2 millimeter balloon to make it a bit wider? House accepts.
Shaft of the left inside still some sorts of.
Shaft, that is not the shaft, proximal part. Proximal part, it seems to be a bit lower, but we have done with 5 balloons, and so I think it has well dilated and well accommodated with the.
What is the comment from Hafiz Bhai regarding shaft and proximal segment of the stent?
I think it's okay.
May I ask the panelists, should we do the IVAS again?
Can we give IVAS? IVAS run?
And any FFR for the LCX or IVAS for the LCX?
Left pin.
And for this case, for this LCX, should I go with DFR? Unnecessarily. I do not think that it will be positive. It will be definitely negative.
Any more manipulation?
Yes, more manipulation I do not want. So, regarding the proximal part,
So you are taking?
again I am taking that fat balloon, but as because it has lost its contour, and that is why I do not want to do further manipulation. No.
Just the IVAS.
They don't become very much bulky.
Become very much bulky as because the you know the balloon is empty, and that is why it is a bit harder, as well as after inflation it has become bulkier. IVAS, do you want to see the IVAS?
Should be the IVAS to the LAB.
If balloon can be delivered in the left lane, you can do further push dilatation. So better, bigger the diameter, better is the.
That's right. That's right. Happy. That's it. Alignment with the. You should have to make alignment with the catheter.
I think the only way is to keep the wire insert, then take back the wire in LAD and go with that wire without coming in the guiding catheter. With that wire, go to SER, and then you are sure you are crossing the stent correctly. Because I think if you have any resistance there, don't push, because this will deform the stent outside.
Yeah, deform the part of the stent. Correct.
Actually, actually what I see from Anjo. I no need to do anything.
Right. I also think like so, and I am withdrawing the circ wire.
If we start with the circ without any significant, that big circ, usually angiography, little pinch, we are okay. But I would, if anybody wants to look at, I would be settling for an IFR. And Omar also agreed, because sometimes going with the IVAS catheter after this, it can be problematic, and you can have a potential for deforming the stent struts. But
Stent
we
struct.
will see. The IFR at this point, 0.9596, I think is very reassuring.
You see, this is the final picture. I think it is acceptable. Let it.
Now it's.
Jamal, as you are wrapping up, I want to make sure that we are all in the same page regarding
Yes.
doing this procedure. What is the clinical setting? This clinical setting can be different. Left main, we are talking about LID intervention. What is the patient's LV function, end-diastolic pressure? These are all
Yes.
important issues. Please pay attention to those also, because it is a totally different ballgame if it is a stable CAD presenting like this, or somebody coming with a decompensated state in terms of hemodynamics or in terms of acute coronary syndrome. It can be totally different. And then your ischemic time tolerance may be different to the patients. So rapid inflation, rapid deflation, and then you can
That's
do
right.
what I call the double deflation technique, and then get the balloon profile less, and then get the balloon out in a way that you don't cause a longitudinal stent deformity. So these are all very, very important steps.
That's right. For this patient, practically his blood pressure is normal, and his left ventricular function is LVEF 65%. His hemodynamic is all right, as well as his LV function is all right. He has only angina on exertion, minimal exertion, that is MISA class 2 to 3. And for that reason, he has also done an ETT. And ETT was strongly positive. Then came to the consultant, and consultant done the angiogram. I have told that another 2 weeks required to understand him, to convince him that he will require some procedure. And
Before
so,
you have
yes.
3 minutes more. Before completing this live case, we have to know that because the DR chat, what will be antiplatelet regimen? How long will continue dual antiplatelet, and how long single?
yes.
As because the young chap, very young chap, only
How-
4 years old. And he doesn't have any important respect of only feminist is positive.
I like to continue 1 year dual antiplatelet therapy, then single antiplatelet therapy. Do you want to differ with my opinion or the House, Chaudhry Hafiz? What is your opinion?
No, I certainly will agree that maybe long term, because this is a problematic lesion.
Now, long term meaning that long term dual antiplatelet or long term single antiplatelet and 1 year dual antiplatelet.
I would definitely go for 1 year.
Yes, my idea is also that at least 1 year dual antiplatelet therapy should be continued,
Probably.
and that single antiplatelet switch over. There is no indication anywhere that dual antiplatelet therapy should be continued for younger one for longer time. So far, do you agree with me?
Yes, agree, but the question is left main.
So
So
is
if you
there
don't
any-
have any huge bleeding problem, then I would argue that probably longer is better. But I have another question for you. How will you follow up this patient?
Follow up, you understand the scenario of Bangladesh. You shall have to follow up the patient. If I want to follow up it perfectly, then I shall have to go to his home. But it is not possible. Even then, we are following this patient over telephone with their attendance, how he is, whether he has any complaint, and after 1 month, 3 months, 6 months, usually they come. usually they come and clinical follow-up is most important, and followed by treatment. If he have any symptom, he will develop any symptom, then I can do treatment once again to see whether there is changes in treatment or not. And by this way, we can follow up these patients.
So no, during the follow-up period, we don't need to do any follow-up studies. We just treat them with the dual antiplatelet, routine cholesterol check, and the risk factor, aggressive risk factor modifications, correct?
That's
So,
it. In this case, aggressive lipid lowering agent also shall advocate.
Sir, this is a chronic stable angina TT positive. Whether DAPT agents should be hypotensive or clopidogrel aspirin or ticagrelor or casoprolol.
And
Because it
DAPT,
is a stable case, chronic stable case, chronic CCS.
in this case, usually clopidogrel is usually advocated, and here, so far I know, ticagrelor is not advocated. What is the idea regarding it? So there have this, Professor Nessa.
I don't know, I cannot, because the question about ischemia versus the bleeding, right? Ischemic because if you look at the cardiac data, there is not an increased bleeding. And in Bangladesh, I have this issue that bothers me is about the clopidogrel and polymorphism. So maybe at least we give dual antiplatelet with ticagrelor 1 month, and maybe you can go and scale down after. But if the patient doesn't have any bleeding, remember she's 27, she may end up with more bleeding problem. In that case, it's all about the risk and benefit. So that will be my view. Imad may differ.
I mean, so that much data showing that in single stenting, large stent, left phase stent, Onyx 30 second generation, no need for long double anti-radiation therapy. So that should 3 months maybe. What I am doing in my cath lab, in my hospital, I am still using clopidogrel.
Dr. Imad, do you use clopidogrel in SES setting? And do you use clopidogrel in SES setting doing PCI? Acute coronary syndrome?
If he is, also in acute coronary syndrome, we will prolong maybe more that, but same, we will use clopidogrel as well.
But it is told, so far I know, that in acute coronary syndrome, ST division myocardial infarction, first you choose the ticagrelor. If it is not available, you can go for rasuprel. If not available, then you can go for clopidogrel. Then here I like to say that ticagrelor has more potency over clopidogrel as per the guideline for STEMI with PCI. Do you agree?
Well, maybe in very high-risk patients, that means diabetes, diffuse disease, and so on, I can change my I can shift to ticagrelor. But normally in not high-risk patient, I'll still using clopidogrel. We are following all our patients, and I would say that accordingly also much data coming from literature. I think no significant differences would be.
What about the clopidogrel resistance in your practice? And do you suggest to see the clopidogrel resistance before starting the clopidogrel? And what is your practice? Dr. Imad? Regarding clopidogrel resistance, what is your experience?
No, we do not do that. We do not test,
Yes,
naked
yes.
test for anybody, but I mean, if patient will be coming with some problem, of course we'll check. But I will say that we have it very rarely. Very rarely.
Meaning that tuberculosis resistance is very rare.
Only thing I beg to differ is that this is left main young patient. In Bangladesh, there is this genetic polymorphism with clopidogrel. So you
Yes.
can afford to give at least the part of the time like endothelialization. So this patient doesn't have any diabetes or anything. Yeah.
In this case, I shall advocate for